NIHR ARC South London Inside Research seminar. It's one of a series of seminars which have been taking place over the last few months, which is exploring the work of the NIHR ARC in South London. This particular session is focused on reducing the harm caused by smoking and alcohol, particularly on how applied health research is investigating the interventions that potentially can be used to improve public health. So it's a really important topic. My name's Emily Finch. I am a consultant addiction psychiatrist, and I'm clinical director at the Maudsley for both addictions and for one of the boroughs. But my clinical work is with people who have alcohol problems, so I'm well aware how important this topic is. I think it would be good to go straight on. I'd like to welcome Dr. Debbie Robson, who's a senior lecturer in tobacco harm reduction at King's, and she's the ARC's Public Health and Multimorbidity Theme Lead. So, Debbie, I'd be grateful if you could start and take everyone through your presentation. Can I also say that we are recording this session, if people are happy with that?
Hi everyone, can you hear me okay?
Yep.
And can you see my full screen or my note screen?
Full screen.
Fabulous.
Debbie.
I'll kick off then. Thanks very much, Emily. So as Emily said, this session we're gonna cover the work we've been doing in South London to help people stop smoking and why smoking still matters. And that's largely because smoking kills around 200 people every day in this country. And every day of continued smoking reduces average life expectancy by about 4 to 6 hours. So what we're going to be looking at in this session is going to tell you a bit about the National Smoke-Free Goal and what this means for people in South London, and what you can expect if you're a smoker and you come into our local hospitals, and some people's experience of local tobacco dependence treatment. So currently smoking prevalence in this country is around 14.5%. It's never been as this low. And that equates to about 6.5 million smokers in the country. And many smokers around the world are working towards achieving a tobacco prevalence of about 5% or less in the next 20 years. That's what is defined as being smoke-free. And the UK government have an ambition to achieve this by 2030. But 5% of smokers is still a lot. So that would be still about 300,000 in the UK or 50 million worldwide. And there's concern that it will be those with the current highest smoking rates that might get left behind. So we need to make sure that kind of the 5% aren't people with the highest smoking rates, which are people from with low incomes and people from a mixed ethnicity compared to others, and people who experience mental illness or substance use. Smoking is also linked to poverty in housing. So currently about 1 million people in this country, including 250,000 children, live in poverty due to their dependence on tobacco. And smoking is linked to housing. So the group of people with the highest smoking prevalence are those without any housing, those who experience homelessness, compared to 8% who own their own home. So based on the work of the Royal College of Physicians, and based on the previous rate of decline, if business as usual were to continue, people living in the most deprived socio-economic conditions are likely to lag far behind that 2030 target. And women who experience the most deprivation will reach it by about 2050, whereas men, they won't reach it till after 2050. So what does this mean for South Londoners? So there's about 1.3 million people in London who smoke, and an estimated 419,000 who live in South London. And that varies by borough. So currently, according to GP practice data, Lewisham has the highest proportion of smokers, but Lambeth has the highest number of smokers. And Wandsworth has the lowest proportion of smokers, whereas Kingston has the fewest numbers of smokers. And these proportions are actually the lowest that they've ever been. Smoking is reducing year on year. But it often, these local rates and the national rates often masks that there's this large gap between those with and without mental illness who smoke. So locally, kind of across all our South London boroughs, in the wider general population, 15% of people smoke, whereas it's 2 to 3 times higher if you experience a mental health condition. And those in our substance use treatment services, the majority of them smoke. And the NHS has come an awful long way since the days when nurses and doctors used to sell cigarettes at the bedside or light a cigarette for a bedridden patient. And it's only been since 2008 that smoking's moved out of smoking rooms in our hospital wards, acute wards and mental health wards, out to outside our hospital front doors and specially erected shelters and gazebos. But only relatively recently that we've had health policy nationally that discourages the facilitation of smoking within hospital grounds. So not just mental health, but general hospitals too. And also there's been a drive to help people stop smoking. And that's largely been funded through the NHS long-term plan. So by 2024, all people admitted to hospital, whatever type of hospital you go to, should be offered funded tobacco dependence treatment services. And that includes for those in mental health specialist services and learning disability services, that should include the option to switch to e-cigarettes during an inpatient admission. So the next half of the presentation, we're just going to give you some highlights of how South London ARC and the previous Clark supported the implementation and evaluation of smoke-free policies and tobacco dependence treatment pathways across our King's Health Partners NHS Foundation trusts. So within SLAM, since 2013, SLAM have just made huge improvements in improving the infrastructure to support a smoke-free site and help people quit. And they now have 14 specialist tobacco dependence treatment advisors across their 4 hospital sites who also follow people up at home. And people are offered evidence-based care, which includes the offer of e-cigarettes to help people temporarily abstain from smoking during an admission, or help them to take the opportunity to completely quit. There's a robust staff training pathway, and what we've been doing is working with the trust to understand and address some of the barriers to implementation, such as staff and service user concerns, such as just not having the time to help people stop smoking, and concerns that service users just won't want to engage in support, or staff and service user concerns that violence might increase if people are not allowed to smoke. And what we've been able to demonstrate through our Clark and ARC work is that staff cannot free up their clinical time to support people to manage their tobacco dependence by not supervising and facilitating smoking. So we worked out they could free up around an average of 2.5 hours per day per ward. The changes in the infrastructure made it a lot easier to identify and record smokers' status, and the recording the smoking status, so knowing who the smokers are, went from 11% in 2011 to 91% this year. And also the uptake of support to either temporarily abstain or quit has gone up to 70% from 17%. And when we've looked closely at this, we've worked out those people who agree to support, they experience the greater, those from kind of who experience greater levels of deprivation and poor health and social functioning. And then we've also been able to demonstrate that violence doesn't go up, it actually reduces by an overall of 39%. And we worked this out by looking at the 12 months after the policy was implemented relative to a few years before. And the people that we talk to about their experiences in either our patient and public involvement work or within research studies, and these quotes come from service users in a local drug and alcohol service where we integrated a tobacco dependence treatment service there and introduced a choice of e-cigarettes. What they really valued was having this support in the same place as where they were getting their support for their drug and alcohol use. And the value of the relationship with a tobacco dependence treatment advisor was really, really important. And they felt seen and heard by the advisor. And so many people just expressed so much gratitude for being given the opportunity to quit smoking when they'd been successful at actually kicking other habits and addictions. And a few people said, this has literally saved my life. So moving on to what's going on in our acute hospitals, there's some great work going on in King's College Hospital and Guy's and St Thomas's. And what they've been doing is piloting what's considered a gold standard treatment for smoking cessation. And we're just going to share a video with you now that was originally filmed for the South East London Population Health Conference, which showcases some of the work of the local Vital 5 work. So I think Flavia is going to take control of my screen and show you that video.
I'm Aaron Woodhouse, lead tobacco dependence specialist at King's College Hospital. I lead a team of specialists and coordinators in tobacco dependence work. We implemented a model, the version of the Ottawa model of smoking cessation in 2020. We've now been running for over 2 years and with great success. Our aim is to basically deliver good quality care and support to inpatients that smoke whilst they're in hospital. And that may be to make a quit attempt with or without medication, or to temporarily abstain with or without medication whilst during their admission, and then on discharge we follow them up with routine phone calls to check on how they're doing, give support and refer as appropriate to good quality local support. First principle is screening. We need to identify the smokers. So this is usually done by the nurse team on the wards. Everybody that comes into King's should be screened for their smoking status. Once we know that, we can sort of deliver specialist care. So on selected wards here at King's, 9 wards, if you're on that ward and you're identified as a smoker, you will receive a visit from a tobacco dependence specialist. We've got a great team of specialists who will come and assess people's smoking behaviour, talk about the addiction side, and also really find out what's happening there and then, and the here and now. Are they comfortable? Do they need some medication?
I'm Geraldine. I've just come to see you as we've been flagged up that you're a smoker, and I just wondered if you wanted anything to help you with any urges that you may have.
I do, because I do smoke a lot. I do love my cigarette, but I would like to try and pack it up.
Okay.
But the crucial thing is, we'll also give the specialist that sees the patient will try and give a call. We'll try and do a phone call 3 days after the discharge, and also at 14 days to really sort of try and have a smooth transition of a nice continuous care, and then they'll transfer to our excellent team of coordinators who will then carry this on every 30 days, from 30 days post discharge up to 180 days.
So if he already has the patches, he may just need the inhalator. Would he be interested in using an inhalator?
Smoking is more than a lifestyle choice. It's something that's often used, but I would say it's more than that. Coming to hospital is a golden opportunity for us to sort of deliver this intervention.
I think I was 15, I started in school, and I used to hide it from my mum and dad.
Yeah.
But I wished I never. It's not a good thing. I'll get up first thing in the morning, I stick the kettle on, I go outside while the kettle's boiling for a fag.
Yeah.
What's that all about? Yeah, no, I want to give it up because my husband don't smoke. I've got 3 grandchildren and I want to do it for them.
Yeah.
You've made me more determined.
Oh, good.
Because any other time, I just feel that a lot of people don't sort of go on, yeah, like when you sort of go to the doctors.
Yeah.
But I just feel that your enthusiasm coming up here into the ward and speaking to me while I'm feeling generally unwell,
Yeah.
I think you've done amazing.
Thanks, Flavia. So if you put my presentation back on, I can continue.
Debbie, sorry, I don't think I can. You need to reshare.
Say that again, sorry.
Can you share again your screen?
All right, okay. Is that okay?
We can't
So-
see the full screen. We can only see the.
Okay. Not sure how I. That one?
It might be one of those icons at the bottom.
Okay, shall I just continue? I've only got a couple of more slides. So can you see my full screen?
We can see the notes page, Debbie. It's got the slide and it's got the next slide.
Okay. And what about now?
No, doesn't make any difference.
Okay, I'll just continue then. I've swapped it over, but I'm not sure what's happened. So I apologize for that. But anyway, so the work Aaron has just described, what we're doing is currently analysing about 2,000 inpatient data for people admitted over a 12-month period. And like similar to people in SLAM, the majority of people do take up the offer of tobacco dependence treatment support during their hospital stay. And some early findings that we've just worked out is that people at King's, 17% of them stay smoke-free 6 months after discharge, and that might not sound a lot, but in the smoking world, that's a huge amount. And what people have been telling us within King's once they've been discharged is this was something they'd never ever considered before. So there was one lady who'd smoked for 30 years who managed to quit smoking, and she said she was just a bit delirious when she first went in, and the last thing she thought was, you know, why on earth are people giving me patches? But she stopped smoking. And then another chap who, again, a long-term smoker, who was only there for 3 days, was smoke-free, and thought, well, I may as well carry on. I never planned to go into hospital, but I never planned to stop smoking either. So smoking is associated with inequalities in our local boroughs. And if you smoke and are admitted to one of King's Health Partners hospitals, regardless of your medical or mental health condition, you should expect staff to offer you tobacco dependence treatment. And that support should be evidence-based and it should be compassionate. And our evaluations suggest that this is happening, but we always are trying to do better. So for the remainder of the ARC, what we're going to be doing is our next steps are going to be to evaluate the implementation of tobacco dependence treatment in community mental health services. We're going to be looking to train some non-healthcare workers, and we're looking for collaborators to do that. We're just about to start to study looking at the effect of vaping compared to smoking on the health of people with severe mental health conditions, and we'll continue to support the local hospitals in their evaluation of their work. And then just a bit of to flag up, we're looking to extend our nicotine and mental health patient and public involvement group, and I can give you some more information about that later, but there's a link to a website there about the group. Thank you very much, and I'll unshare my slides and note slides.
Thank you very much, Debbie. That was perfect timing. Can I just add, and I didn't mention at the beginning, that we're going to have questions after Beverly's session, but you're welcome to put questions in the chat as we go along. And once we get to the Q&A session, you can put your hand up and we will hopefully get to you. What I'm now going to do is go on to our next set of speakers. We have Eileen Robin and Sophia Vasanji Hemraj, who are both doctoral researchers at King's, and they're going to talk us about 2 different strategies and interventions for helping to reduce harmful drinking. So if I can hand over to Eileen and Sophia. I think Eileen's going first.
Thank you. Let me just share my slides. Can you see them okay? Great. So hi everyone, I'm Eileen, and this is my presentation on my PhD, which is exploring transdermal alcohol sensor devices.
Actually, Eileen, they're not on slideshow. They're on, that's better.
Is that
That's
better?
Yeah, perfect.
Oh, perfect. So what are transdermal alcohol sensor devices? So these images are examples of a few different brands. Transdermal means through the skin. So in this case, we're talking about consumed alcohol coming through the skin. When alcohol is consumed, most of it comes out through the breath and urine, but about 1% comes out through our skin. And these devices can be worn on either the wrist or the ankle and measure this alcohol. The reason why we might use these devices is because they can measure alcohol continuously and objectively throughout the whole time that they are worn. This could be days, weeks, months, depending on how long someone wants to wear one of these devices for. And this would allow monitoring of alcohol consumption in everyday, real-life context and in near real time as well. There's about a 30 to 60-minute delay on these devices, just to do with obviously the alcohol being metabolized. So these devices are able to address some of the limitations of other alcohol measures. In alcohol services at the moment, currently breathalyzers, urine tests, or drinking diaries might be used with clients to record how much alcohol they have drunk, but breathalyzers and urine tests have a couple of limitations in the amount of data and the length of time they capture of alcohol consumption. And drinking diaries can be forgotten, and it's hard sometimes to remember everything. So the research on these devices have only recently started to grow, especially in alcohol treatment settings. But in the last year in the UK, the criminal justice system started using them as well. So these devices do have the potential to be used in alcohol treatment, and this research that I'm conducting is going to explore that potential. So my PhD has 3 parts of it, all focused on a different aspect of these devices. So firstly, we've already looked at the accuracy of these devices, because if we were going to use them in treatment, we want to know that they are accurately and correctly measuring someone's alcohol consumption. Secondly, we've looked at the acceptability of these devices, because if they're going to be worn by alcohol clients, we want to make sure they're not adding an extra burden or responsibility or disrupting their life in any way. And finally, what we want to do is we want to examine if they would be feasible to conduct this kind of research as a larger trial, and if they would be effective as part of alcohol treatment. So from reviewing the current knowledge, what we have on these devices, we know that the research that was already being conducted is not consistent. There's a range of different techniques being used to test the accuracy and the acceptability of these devices. Each researcher seems to use their own way of monitoring alcohol, using it with clients and analysing this data. And this means it's not easy to compare the results between all the research being done. The present research also tests these devices mostly with people who are not alcohol dependent or accessing treatment, mostly with the general public. And as with each group of people, there's many differences. And so if we want to use these devices in alcohol treatment, we believe we should research using those we intend to use them with. So people, for example, with an alcohol dependency or those accessing alcohol treatment. And that's where my studies come in. We're looking to recruit participants from alcohol services. We think this group could have a big impact from using these devices, and so that it's really important that these individuals should be involved in helping the design of the study and being able to participate in this research. Due to this, we've also run some PPI groups with service users and service staffs in South London services and included them in the process throughout designing these research projects. What we've also found looking in past research is that there's a lack of research on what people think about wearing the devices. So many studies look to see if they would work well or if they were accurate. However, we also want to know if they're comfortable, wearable, and can be worn for a variety of activities, such as sleep without interfering and disrupting the wearer's day-to-day life. And this is why we've conducted one of the studies looking at examining these factors while alcohol patients wear it over a 1-week time period. But there are other concerns we are aware of that we also are going to be looking into that we think are important to consider as part of this research. So for example, if there is a stigma about wearing the device and if they would be embarrassed to wear it in public, how do people feel about constant monitoring of these devices? And if there's any concerns about the devices being locked onto an individual and unremovable by the wearer, that particularly is in criminal justice settings and wouldn't be so much in clinical treatment. And we are aware that these devices could be considered controversial. However, in our research, everyone involved who's used them or has worn them willingly, and they are also keen to learn more about the potential benefits of these devices in treatment, we found. So some initial results from my first study looking at the accuracy of these devices. So the top graph looks at 2 brands that we used, which is the Backtrack Skin and the Smart Start Bear. And you can see they kind of are quite close, monitoring the alcohol consumption over an afternoon period. And then the graph below is the breathalyzer data. So they do look slightly different, and we expect that just due to how alcohol would come up through the breath or through metabolism through the skin. But they both kind of measure the same thing. And from our results, it looks like there is kind of a correlation between these devices, which is really good. And here's also some initial results from the acceptability study, the study where we asked people to wear the device for a week and how they felt about wearing it and if they liked wearing it in their day-to-day life. So the initial feedback found that participants did not feel restricted at all. They felt like they were wearing a normal watch, which is really good. And they really quite like the design. It's quite small and sleek. They liked that they could prove to their key workers that they were abstinent for certain days or had been able to reduce their alcohol consumption, and all found the device really easy to wear with very little training needed to wear it for a week. Staff that I talked to also admitted of being wary of these devices at first, but after seeing some of their clients wearing the device over the week and the positive benefits they received, they changed their mind and they actually were quite keen on these devices as well. And it really changed their thoughts on the technology. So the results I found from my research so far have been quite positive, which is quite good to hear. And that is all about my research, and just thanks to NIHR ARC South London for their help.
Thank you very much, Eileen. Thank you very much. If we could move on to Sophia, please. Thank you. Sophia, are you okay to go?
Sorry, I realized I was on mute. I'm just about to share my slides.
That's fine.
Are you able to see them? Okay, so
yes, that's fine.
Hi, my name is Sophia, and I'll be talking about strategies to reduce harm caused by alcohol by using a therapy called contingency management. So my research focuses on patients diagnosed with alcohol-related liver disease, so ARLD. This refers to damage to the liver caused by alcohol intake, and there are several stages of severity in a range of symptoms which are barely felt until the liver has been severely damaged. This means that usually ARLD is diagnosed alongside tests for other conditions or at a stage where the liver is already severely damaged. So as you can see from the graph, 78% of deaths linked to alcohol are correlated to ARLD, and the rates have been growing through the past decades. Most of the patients are usually male, between 55 and 59 years old, and most usually from deprived communities, meaning that ARLD further contributes to health inequalities. After being admitted to hospital following an acute liver episode, very few patients attend the treatment they've been referred to after being discharged. This can be for reasons such as physical health or often not understanding how their drinking is currently affecting their liver health. And because they do not attend treatment, this often tends to lead to relapse and readmission in the future. So through time, patients can see both their liver health and their drinking, they can see their liver health affected, whether their drinking levels remain the same or but they usually get worse. So our research focuses on therapies to reduce harm in patients diagnosed with ARLD, because this group is already taking a large number of medications for their physical health. Often what is the case is that when they are prescribed with medication to reduce alcohol cravings, it just adds more to their medication overburden. So for example, talking therapies such as counseling can help improve their overall health by reducing the harm in this population. So what our team is currently doing, we have looked at the available evidence on how therapies can be used, therapies such as relapse prevention, cognitive behavioral therapy, peer support can reduce harm in this group of patients. However, the results did not show that any specific therapy was sufficiently helpful on either reducing drinking levels or inducing or in maintaining abstinence. So this points a need for a new and different strategies and approaches to be explored. So contingency management is a therapy that uses small rewards, usually in the form of shopping vouchers, to motivate a specific behavior. This behavior could be, for example, medication compliance, turning up for treatment or appointments with their doctors. It is ethically approved by the Department of Health and Social Care and for very specific situations, and it is also a recommendation for substance misuse treatment. And it actually has been shown to be very highly effective in patients with opioid or alcohol dependence. And it is also cost effective. So by using contingency management to incentivize patients to attend treatment and engage with services, the overall cost of the contingency management intervention is also less than the medical costs that patients would mean by not attending treatment. So we are hoping to adapt this intervention specifically to this group of patients, as this has not been done before. So our study will be small scale as we want to see how feasible it is to conduct a larger scale trial across England. We will be recruiting participants through the alcohol care team from King's College Hospital. So as you can see from the diagram, after a patient being admitted, the alcohol care team will refer them to the study. And if they read after enrollment, patients will be offered addiction, liver care, and therapy follow-ups over 3 months. We are aiming to include an overall sample of 30 participants, so 15 in the control group and 15 in intervention, meaning 15 patients will be receiving contingency management. So for each of the treatment points, this could be appointments with addiction specialists or pathology services that a participant turns up to, they will receive a small but increasing shopping vouchers. We have also conducted focus groups, so me and Eileen, over the course of a few months earlier this year. And we have taken this input when planning the research so that it is more relevant in a framed accordingly. Some of the findings from the focus groups were that the intervention was well received, it seemed appropriate to reinforce treatment attendance. Service users also expressed that they would prefer to have their interviews and meeting with the researchers face to face, as they would feel more comfortable like that. But they've also expressed that they would be keen on being offered the choice to also do it remotely, either through call or through Zoom. So again, with our research, we are aiming to investigate patient treatment experience, how contingency management is viewed and perceived, and further dig into reasons why patients do or do not come to treatment. We are hoping that our research will help cater patients' needs specifically to this clinical population, as this has not been done before, by developing a tailored intervention to improve their overall health. And currently we are in the final stages of getting approvals in place, so we're hoping to start recruiting soon. Thank you for listening.
Thank you very much, Sophia. We are now going to move on to Beverly and colleagues from Mosaic Clubhouse, and we're going to ask you to offer your thoughts and perspectives on what we've seen so far, and then we're going to go on to question and answers so people can be ready with their questions.
Hey,
so over to Beverly.
I'm Beverly Randall. I'm Programme Manager for Mosaic Clubhouse. So I've got 3 of my members here that are going to feed back to what they've just listened to. So I'm going to start off with Kathy. Carol, sorry, even. Forgive me, Carol.
Into London, it's okay, but you're starting off. Why don't you just start off with anyone who's ready?
Okay, who'd like to go first?
Okay, so I'm Paul. For me, I was recently discharged from Lambeth Hospital. So when I first got onto the ward at the hospital, what happened was I was told that because I'm a smoker, that I wouldn't be allowed my rolling tobacco with me. I was offered a e-cigarette or a vape for my admission, which I was quite surprised with. So I chose the vape, and throughout my admission, that kept me through and everything in that. And when I was allowed out on escorted leave and that, my first thing was to go for a proper smoke. But upon doing that, the taste and smell of it was just that disgusting that I ended up throwing it away and going back to the vape. So the vape treatment that was offered to me does work. I would say from my experience as well, it depends on the individuals. Some people are adamant about continuing to smoke and that. Others will take the treatment, like the replacement, because that's the only option there is. So if you cut out the other options, it definitely works, from my experience anyway.
Okay. Thank you, Paul.
Okay, I can add a bit to that. I think following on from that, because when I was in hospital, they still had cigarette breaks, and I couldn't. When I learned that they'd stopped smoking in psychiatric hospitals, I don't know whether it was the same time as other sorts of hospitals. I couldn't actually imagine being in hospital without a cigarette break, so that's all been quite interesting. But I've just managed to give up. I'm in the process of giving up. I'm sort of about quite a few weeks in now with the NHS local stop in team. It's I don't know how many times I've started on the course, but this time it just seems to be the right time, so I'm feeling committed, and it's being pretty successful at the moment, and I've got quite a lot of thoughts about the whole sort of stop smoking process, especially to such a long-term heavy smoker as I was, because I noticed that woman there was saying they were talking about people who smoked 30 years, 40 years. So I smoked about like 45 years. So I was yes, long time. You gasped. I don't need that, thanks very much. Okay, so actually that brings me to another point that I was definitely going to get to. Just be very, very careful about the negative comments that the negative factors that you present to people in the stopping smoking process. Like there was a statistic sort of quite early on in the beginning, which I can't quite remember the exact statistics for. I'll probably choose not to look it up, but for however many days or cigarettes smoked, you lose days off your life. Well, you know, someone who's quitting smoking doesn't really want to know that, because that's the sort of thing that's just going to keep you smoking. And on that point, I'll just end. Thanks a lot.
All right.
Thank you.
Will you introduce me?
And this is Carol, finally Carol.
Another Carol. Hi, yeah, I just want to make a few points here on smoking and also on alcohol. First thing, I spoke to somebody who had been smoking for many years. They started smoking at the age of 16, 17, and they started smoking because of the peer group they were in. They also spoke about they found that there was not much information at that particular time when they started smoking about the health impacts of smoking. And later on, when they did find out about the impacts of smoking on their health, they still carried on smoking because they did not feel that anything was happening to their health. But anyway, moving on. They then decided after some time to stop smoking, and they had been referred by their GP to start on the nicotine patch. And they said that worked for them quite well, and they stopped smoking for over a year. Anyway, going on to talk about alcohol. So finished talking about the smoking. So about alcohol, I also peer supported a family member and attended some of their key worker sessions, and they revealed that their alcohol situation was down to issues with dealing with stressful partners and not being able to see their children. Anyway, so now with regards to the prevention of the methods of stopping alcohol drinking, would be a very good idea is the actual device that you just presented. I feel that person would do very well with that actual device. Also with the face-to-face with the key worker to ensure that they were using the device properly and to prove that they had been abstaining away from drinking. I don't think I have anything more to say on that, but that is all I have to say for now. Thank you.
Thank you. So I'd just like to add as well that Mosaic Clubhouse is a no smoking building, and also we're quite disciplined, so if anyone ever comes and they were drinking or anything, they would be asked to leave. And I think that trust element as well, it's that the relationship building that we have with our members, that means that, you know, they themselves don't want to do that while they're here. So I think that's a part of breaking down the barriers as well, that we actually trust people and that we have relationships with people and that people can be honest with us. So that's a positive thing.
It is, and can I just add one final point, because I know we've only got 5 minutes. I'll just say, like, in addition to what you're saying, Beverly, I think that what I get from Mosaic is that just generally and all round, it promotes both by example and sort of certain practices and whatever, things like this. It encourages generally healthy lifestyle, of which obviously smoking, not smoking is part. So that's something else to be considered as well.
Which is very positive.
Mhm.
Okay, can I now move on to questions from other people on this call? I think there are some comments in the chat so far, but I don't think we've actually got any questions. So if anyone wants to put anything in or raise their hand, that would be really good. Hamid has commented, and I think he's asking a question really, but he's asking, is vaping increasing? And I think that's probably for Debbie.
So vaping isn't increasing much in the adult population. So smoking prevalence is about 14% nationally. Vaping prevalence is half of that. It's 7% nationally, and it's gone up by 1 percentage point in adults since 2019. Where it is increasing is in 16 to kind of 19-year-olds. So in people under the age of 19, it's gone up from about 4% to 8% from 2019 to 2022. And the majority of that increase is in the kind of older children, so 16 to 19, and largely driven by these new disposable e-cigarettes that are on the market.
Debbie, does that worry you?
It does, yeah. Not the adult people vaping, because vaping is considerably safer than smoking, and so we would always encourage people who smoke and who struggle with quitting to try vaping and try and switch completely vaping as a stepping stone to giving up nicotine completely. In terms of young people vaping, it is a concern, and we're actually launching a big report tomorrow that we've written for the Department of Health, which covers the safety of vaping. So yeah, that will be in the news tomorrow night and Friday morning, likely.
Okay, thank you, Debbie. I think Hamid wants to come in, and then Diane.
Thank you so much. Hi, I have thank you. Can everybody hear me? Hi, I have a quick question. And the question is that I'm a quitter. I don't smoke, but I did take part with Action Against Smoking for Health and did a video for them, which was great. And also recently I took part in another smoking, the views of Black, Asian, Nordic ethnics and quitting smoking. And one of the things I want to say is my concern is that cigarettes are extremely expensive, extortionately expensive. And now a lot of people are smoking tobacco, which is not regulated. And I wanted to find out, Debbie, what is your view on unregulated tobacco that is what people are smoking? And also, people assume that shisha is not dangerous and it's not unhealthy and it's supposed to be cool and amazing. And that's another concern I have. So it'd be really nice if you could answer both of my questions. Thank you.
Thanks for your question, Hamid, and nice to hear you again. So smoking is uniquely dangerous, and unregulated illicit tobacco is even more dangerous. So it hasn't gone through the kind of correct notification procedures with the government. And whilst it might be appealing to smokers to kind of, go to Brixton Market and buy tobacco from a market stall, which is likely to be unregulated, it unfortunately usually contains kind of the worst parts of tobacco. It'll contain rat droppings because they sweep up all the detritus from and debris off the floor from when tobacco is made. It has higher concentrations of lead and chemicals like that. So not a good idea, but it's understandable what, you know, the current financial situation and living crisis will drive people to buy in illicit tobacco. In terms of shisha, you're right, Hamid. It also isn't as kind of so, you know, some people will see it as cool, but the fact that you're heating tobacco or even non-tobacco shisha over coals, anything that you inhale that's been combusted in some way and heated to high temperatures, whatever your drug of choice is, isn't going to be good for your respiratory system. So yeah, you're absolutely right.
Thank you. Thank you.
Okay. Diane.
Yes, hi. Can you hear me?
Yes.
Hi, Diane.
Okay, hello. Yeah, I've got a comment and I've got a question. The comment is about smoking. And yeah, I think it's a really good idea to have intervention when somebody's in hospital because they're a captive audience and there are not the same temptations around them. I think the problem comes when that person goes home, which is why I think it's such a good idea that you have a follow-up. I should say, I'm a patient in recovery because of alcohol dependency. And it's really the same as when you detox, because when you detox, you have to decide whether you go in-house or whether you detox at home. I think it's called community detox, I'm not sure. It's actually much easier to do it in-house, but then it's much harder when you go home. So that was my comment about smoking. And I'll go on to devices briefly via drinking diaries. Drinking diaries are quite difficult because the drinking diaries are filled in by the person who has the alcohol issue. And having hidden how much you drink from people for a long time, it's very, very difficult to put down exactly what you are drinking. And in a way, it feels like you're cheating on yourself because you're coming clean with something that you haven't been clean about before. So yes, maybe the device does have some work. I'm sure it does have some very good things. My question about using the device was, do people ever think that it's there for something else? People wear tags for various reasons, one of them involving prisons. And I just wondered if people sometimes thought the device was something for something else and whether that contributed to the stigma.
Eileen.
Yes, so the experience I've had with recruiting participants and also the PPI focus groups is, I would say, 99% positive. There was one person who was worried about their privacy and if it was a location monitoring tool as well. And despite me saying, you know, there is no GPS tracking on this device, he still felt uncomfortable wearing it. And of course, it's an optional thing. People don't ever have to do this as part of their treatment or as part of research. So he declined participation, which is fine. But I would say he's the only one out of maybe 20 people I've approached who had that concern. And that was due to other personal issues in his life that he didn't want to be tracked for. I would say most people really like the style. The device that I'm using in particular looks quite like a Fitbit. It's black, plain black, there's no writing, so you can't even see the brand to look up the brand and see what they make, which it would lead you to backtrack, which makes breathalyzers and alcohol monitoring products. But it's very, very subtle, very sleek. I agree there are some, one of the images I showed was Scram, which looks very much like a house arrest monitor. And I think those used in criminal justice systems don't have maybe the same concerns of reducing stigma or being so covered and subtle. Whereas if they're used for different uses, like in clinical treatment, there would be also obviously that factor which would be considered when implementing them into services and designing these products. But I think it's a really good point. It needs to be considered in this research.
Okay, thank you.
Thank you. One last question. Reshma has got his hand up. And is still on mute. Thank you.
One thing that I've noticed that in all these amazing, compassionate, helpful, emphatic therapies that you medics are providing, are you actually disseminating any literature to them, either verbally or in writing, about the harm that alcohol and tobacco causes, that tobacco causes cancer and other dread diseases like bone and teeth deterioration, and that alcohol has now also apparently medical evidence that it causes cancer, possibly. That at this, whilst providing these therapies, is it going in conjunction with providing education? Thank you.
I think I'll go to Debbie first on that.
Thanks very much, Rashma. Yes, we do provide written and verbal health education to people who smoke in hospitals and in our community services. But as kind of Kathy mentioned and Hamid mentioned, sometimes that needs to be tailored to individuals, and what might engage somebody in a conversation about smoking will turn some other people off. So it's important to kind of check how ready somebody is to receive information, and what do they know already and what do they want to know, rather than just kind of a blanket approach to, with educational materials and messages the same for everybody.
Thank you. And Eileen, is there anything you want to add quickly, because we're going to move on?
No, I completely agree with Debbie. I think it definitely is a case-by-case basis. Some people really want to know all of the information, and then we would be more than willing to help them and find that information for them. But other people, it could be a turn-off. But it's something definitely important to do in collaboration with the treatment.
Okay, thank you, everybody. Now we're going to move to the final phase of this seminar, and we're going to look at, we're going to have some breakout groups. And what the admin team will do is they will put people automatically into a breakout group. You'll have about 15-20 minutes, maybe sort of 18 minutes to discuss the questions which the facilitators will have. We'd ask you perhaps to put your cameras on to make the discussion a bit more meaningful. You need to identify a note taker for each group, and if there isn't one in there already. And we'd like to let you know that we're going to collate summaries of the key discussion points to circulate to the researchers afterwards to inform their work and to ensure they get feedback on what they're doing. You'll notice, and those of you who are experienced with Zoom, there'll be a countdown at the end of the session, and then you'll be returned to the main meeting room. And after that, we will have 10 minutes of final reflections, not group by group, but inviting comments from anyone about the work they did in the group sessions. So can I hand over to admin to put everyone in groups, please? Okay, can we move? Does anyone have any reflections from their breakout group that they want to share? Anyone prepared to kick us off?
I think our group, is Michelle there? No, Michelle was going to do some feedback. I don't mind supporting with the feedback. Hi, Michelle. Are you back?
Hi, Hamid. Yep, I can go
Thank
first.
you. Thank you. Go
And
ahead.
you can add in. So a few of the points on question 1 about practical ideas to ensure people aren't left behind when the country goes smoke free. We thought one of the important things to convey is that it's possible, how, looking at positive stories, particularly for people who are really heavily dependent on smoking, just sort of continuously emphasizing those positive stories that people think that they think it's impossible for them to quit, but showing people who are really heavily dependent and that they did quit, that's really good strategy to use, and also just reflecting on the fact that the law and policies have made a huge difference over the last 30 years. So emphasising, the fact that everyone could smoke everywhere 30 years ago, and now we can't, that things can change, but it's supporting people not just in hospitals but in local communities so that they can, make that change, and just using positive stories. On the second question, just talking about stigma, there's really concern that some initiatives and interventions to help people who are heavily dependent encourages them to be stigmatized. So we have to make sure that they're not, although you're providing that support, but you're not just focusing on them as heavy alcohol or smokers, because that, again, smoking has still got very negative connotations, and so that's something that people are saying needs to be built into any support as well.
Okay.
Anything else to add, Hamid? Don't think.
Thank you so much. I think that was really good. Thank you for coming. I think I just wanted to say a very quick point that we really need to embed equality, diversity, inclusion in the sense that how drinking was a big taboo in certain communities, particularly in Pakistani Muslim community, and now it's become a normalization where people are not seen as a taboo, which means that the increasing of alcohol consumption is very open, whereas before it was taking place, but very quietly, very discreetly. People felt embarrassed to say there was drinking, which meant that some people probably drank less or didn't drink at all. And also with smoking, it's almost becoming it's almost what's happening is we're in a predicament where people think, hey ho, I'm so cool, I don't smoke, but I vape. And to be cool, I've got to be part of the vaping community. And people, even I meet young people and they'll say to me, oh, I don't smoke, I don't like the smoke, but I vape. And it's almost like something's cool about vaping. I'm thinking it's still tobacco. And in the long term, I'm sure we're going to find out that it also affects health in a bad way. So I just want to finish on that one. Thank you.
Okay. Debbie, do you want to make any comment on that?
Yeah. Just to clarify with Hamid, vaping doesn't contain any tobacco. So and it's not combusted, why it's kind of generally much safer. But I do take your point about, particularly about peer pressure and young people. And for those who maybe is not familiar, these are the type of products that young people are increasingly using. But just to the other point there about kind of peer pressure and kind of following the crowd, what I've also heard some young people say recently is vaping's become too popular and too cool, so I don't want to do it and will smoke instead, because they want to be quite different to their peers who seem to be kind of following the crowd at the moment. So we need to keep an eye on this and need to monitor it. Shall I briefly just give a
Debbie, sorry to cut you in, just a quick one. I think what I got confused, where they put like a cigarette inside a vape and they say, oh, it's not smoking, it's heated tobacco. Because that's what I'm talking about. I've seen a lot of young people use that and they say, oh, I'm not smoking, I'm vaping, but they're still putting that thing that heats up and it's still tobacco that Am I on the right lines? Do you understand where I'm coming from?
Yeah, so there's
Oh, good.
it's quite easy to kind of get confused with it. So you've got e-cigarettes or vapes which don't have any tobacco, which heat a e-liquid solution which has got nicotine, but not all vapes have nicotine. You've got the carrier solution, which is something called propylene glycol and glycerin, and then you've got added flavors. But then you've got another tobacco product called heated tobacco products, which is mainly IQOS in this country, and that does have tobacco in it. But actually very few people in this country, and particularly young people, tend not to use the heated tobacco products. They're very popular in mainland Europe, largely because they're so expensive. But yeah, so yeah, I understand those comments and feedback. Thanks, Hamid.
Thank you. Thank you.
Anyone else wants to make a point? Maybe someone about wearables and electronic interventions and apps? Because I think one of the things, Coral.
I just made a point within our group with the wearables and with the apps. I think that they're brilliant. And somebody else in our group kind of made the point of, you know, not one thing is going to help one person. Something might help one person, but it really doesn't help the other. So that's great about having the apps and the wearables. They offer lots of options to people. But I'm a community physio that sees lots of patients that are housebound and elderly. So I'm just quite keen that we don't lose the face-to-face and personal kind of side of support that we can offer. You know, that those kinds of people will get left behind if we spend, you know, if we just offer that basically.
And our group made exactly the same point, that we will miss people who have perhaps very chaotic lives and some of the older people, if we only rely on electronics, take the people out of it. Anything else, or shall we move on to final closing? Okay, I think there is a final slide to go up, isn't there? Aha, Flavia, thank you. Okay, thank you everybody. The presenters for all the effort they made, and the facilitators and the note takers, and primarily everyone who attended and provided helpful comments. And I hope you learned something, and also that you felt you were able to contribute something. Inside Research, these seminars are going to continue in 2023, and there is a newsletter that you're welcome to sign up on, and therefore you will then get advance notice of what's going on. You can follow the ARC on Twitter. And could you also give us some feedback, please? Either a short survey or just put a few words in the chat. That would be very grateful. We'd be very grateful. And also, we're going to share a recording of the event and a short report of the discussion. I presume that goes on the website. Is that right?
Yes, it will go on the website, Emily. Thank you.
Thank you, Michelle. Any other comments from the organisers? From anybody else? Okay, if that's the case, in which case I will close. Thank you for joining, and thank you everybody for everything you did, and have a nice evening.
Thank you very much,
Thank you.
everyone.
Bye.
Thank you.
Bye.
Thanks everyone. Thank you.
Bye all.
Bye.
Bye.